Here are three different causes of calf asymmetries. What are those causes? Here are three symptoms that may possibly turn up in your clinic and can be caused by stroke, VBI, brainstem injury and more. Link them with the definitions in the right-hand column. This week's webinar will be on the abducted ulna, but I'm afraid we'll have to review some of the biomechanical definitions to make sure we are speaking, if not the same language, then at least one comprehensible to you and me. This will be a review of the biomechanical dysfunction of the peripheral joint. It will cover the various types of pathomechanics and their identification and their treatment. Even though it's a basic review, I think that there will be details, perspectives and concepts here that may be unfamiliar to most of you, or at least it will be a helpful alternative way of looking at the subject. Let's get some definitions out of the way so we can speak the same language. They have to be my definitions as I'm doing the writing, but I think most will be in common usage amongst us. I am sure you'll be pleased to note that as there isn't that much information in the medical literature or even the established physiotherapy literature on this subject, there will not be a lot of supporting materials for you to wade through for this seminar. Mostly mine, good or bad. And please, if you have problems with my interpretation, say so and it can be discussed. Articular hypomobility is that which is caused by the joint capsule or its ligaments, arthritis, pain, spasms, adhesions, scars, arthrosis, while pathomechanical dysfunction is still an articular hypomobility, but it is caused by biomechanical problems. This is opposed to the extra-articular hypomobility, which is almost entirely about muscle, hypertonicity, scarring, adhesions, etc. The principal clinical difference between them is the loss of the arthrokinematic or glide with the articular hypomobility and its retention with the extra-articular. A pericapsular restriction is an articular hypomobility caused by structural shortening, such as adhesions, etc., as opposed to biomechanical limitation where no structural shortening is involved. A subluxation is perhaps an unfortunate term, as it can be confused with the surgical definition of a partial dislocation. For the model I'm using, it actually is a partial dislocation, but extremely small in size. It is a joint jammed at one end of its range, causing complete limitation of the opposite movement. However, it is often the conjunct rotation into which it is jammed, so only that part of the major movement is lost that relies on that conjunct rotation. PIVM is strictly speaking any intervertebral movement not caused by muscle action. So it has to include the arthrokinematic, the osteokinematic and the rock and roll component. Loose language over the years has led it to mean passive physiological movements, but it would be better practice to be literal in these meanings. So if I say P-PIVM, I mean PIVM as you probably understand it. The PPM is the equivalent of the P-PIVM in the periphery, and this includes abduction, adduction, medial and lateral rotation, and flexion and extension. The PAM and PAVM are the joint glides, or for arthrokinematic spin, it is distraction. It differentiates articular from extra-articular hypomobility. Segmental and articular stability tests determine if a hypermobility is also unstable. Hypermobility is found by the PPIVM or the PPM and is an excessive range of physiological movement. It may be irritable or non-irritable. If irritable, it is accompanied by pain and sometimes spasm and appears to be of normal range, but halted by either the patient's reaction to pain or spasm. Non-irritable hypermobility is not painful and not limited, given a soft capsular end fill at its end. Instability is a movement that is present that should not be present. That is a non-physiological movement. Examples are appreciable axial rotation of the lumbar spine, abduction of the extended knee, distraction of a closed packed joint. It can operationally be defined as a joint in which a positive stability test is present. The abducted ulna. We're looking for the presence of the general signs for subluxation that we previously discussed. That is local pain, moderate pain, non-obligate functional loss, episodic in nature, and so on. You've got to find the diagnosis before you start looking for an etiology. It makes no sense to look for an etiology before you are fully aware of the pathology present. The pain is generally on the outside of the elbow for the abducted ulna, but it can be medial if the medial collateral ligament or is overstretched, or if the medial common flexor tendon is affected and is overworking. Specifically for this, we see on the physiological movements limited flexion and supination, either separately or combined. Actually, it's usually both of them with a pathomechanical infill. The actual amount of loss of movement here can be really quite small, and the infill is key to making the diagnosis. Arthrokinematically, the lateral ulnohumeral glide test is positive with a pathomechanical infill. Outliers, severe pain, more referral, more functional loss, and don't forget, the abducted ulna itself may not be painful, but is creating other problems, most notably and most commonly a tennis elbow. Differentials: medial collateral ligament tear, lateral collateral ligament tear, a tennis elbow, radiohumeral joint dysfunction, and arthritis of the radiohumeral joint and sometimes of the elbow joint. Abduction is a conjunct rotation of ulnohumeral flexion and is required for supination. If you do not believe that the ulna moves during pronation and supination, fix the lower ulna with your other hand and then try and pronate and supinate. More often than not, this dysfunction is not painful, but has caused a tennis elbow that is bringing the patient to see you. But when it is symptomatic, it usually refers to the lateral elbow. It is usually short-term episodic, with pain-free periods lasting much longer than the painful episodes. Of course, it is quite possible that you might see the first episode, in which case it will be an atypical presentation. The diagram above is both a sequence of examining for biomechanical dysfunction, and it is an organized structure of signs of such a dysfunction. You start with a history that is typical for biomechanical dysfunction, and then go to the diagnostic exams of active, passive, resisted, etc. testing. This gives a diagnosis of biomechanical dysfunction, which takes you to the passive physiological movement exam. If the exam is negative, you have probably messed up somewhere, most likely in the biomechanical exam, in which case a hypermobility is probable, as this is the most difficult condition to detect. In this case, do stability testing, and if this is positive, you've missed a hypermobility. If negative, you will need to revisit the diagnostic exam and/or look for a second opinion. If the PPM is positive, it will be positive for either hypomobility or hypermobility. Let's go the hypomobile route. The hypomobility can be articular or extra-articular. Do the arthrokinematic test, and if the arthrokinematic is missing, that is the PAM is positive, it is articular and not extra-articular. The end field will tell you which, but in all probability it will be a pathomechanical hypomobility. If the PAM is negative, then wobble, that is, perform gentle mobilizations of the joint for a few seconds and retest the ppm. If this is now negative, the problem is one of hypertonicity, and you need to find out what is causing it. If hypermobility is found on the ppm, then articular stability testing will probably find the instability when testing peripheral joints. But this testing is much less effective with spinal joints. If only hypermobile, then it is caused either by neurophysiological problems or mechanical stressing, and you need to find out which of the two it is. Abducted ulna seems to be a common cause of common extensor tendinosis of the elbow. A number of models explain how this is, the most common of which is mechanical, that is, altering the length-tension relationship of the tendon. I've yet to find any clinician who's able to go any further in the explanation of this. I shall give my favourite explanation, as I think it is clearer and a better explanation. The first part is common to nearly all explanations, and I will indicate when this one diverges from it. The subluxation is almost certainly a result of arthrotic instability of the ulnohumeral joint, and this allows it to wander a bit within the capsule and sublux into abduction. This leads to a lengthening of the radius relative to the ulna, and this lengthening pushes on the carpals, shifting them ulnawards. It is this shift that promotes the model of length-tension change, and it is at this point that we take a different path. The wrist, when shifted ulnally, is unable to fully extend and radially deviate, which is a position of strength, so it is unable to generate full power, which is read by the proprioceptive system as needing more force, so the muscles contract more strongly and still fail to generate the force, and so you get overworked muscles. Added to this is the probability that the hypomobility of the wrist results in reflex inhibition and weakness, making the tendon even more vulnerable. At last, given sufficient need to produce power over a long enough period, the tendon degenerates. The following short video looks at one manipulation for the abducted ulna, my preferred technique. For those who would prefer not to manipulate, there is on the linked video depicting assessment and mobilization, a mobilization that you can use. The manipulation depicted is a short lever osteokinematic manipulation which gaps the joint, causing an adduction force to be applied. In another manipulation that is usable is to turn the mobilization on the other video into a single thrust technique. So, this is abducted. If we want to take it into adduction, one way to do it is basically to stabilize the humerus and simply force this over into adduction. Very effective, as I say, but essentially dangerous. We stand a really good chance of rupturing stuff on the lateral side of the elbow. We could come in and attempt to do a lateral glide of the ulna and try and push it across that way. Very safe, but not very effective. So we're going to compromise and do a fairly effective technique that is also fairly safe if it's done correctly. What we'll do is bring the patient's arm around your chest that way so their fingers are flat on your chest. We'll bring the thenar eminence up onto the medial epicondyle of the humerus. Take the arm out of full extension, so you just flex it slightly, okay? The direction of thrust will be actually to abduct the humerus on the stable ulna, which will have the effect of adducting the ulna on the humerus. So we have a short lever osteokinematic technique that will result in gapping on that radial side and hopefully correct this abduction subluxation. We need some assistance from the patients though. So we'll have the patient do a little bit of work for us, and I'll get the patient to pronate their hand into my chest, just gently, and relax. As she relaxes, I'll just take up the slack of that gapping, and again,
and relax, take up the gap, and then when you're ready to thrust, you simply thrust a short amplitude movement across the elbow. Okay. Having done that once, recheck. This doesn't always click when you do it, as all manipulations don't, but this one in particular doesn't always click, and you'll correct it often without any noticeable sound. The abduction manipulation to correct an adducted ulna is essentially the reverse of the one we just looked at. We'll bring the patient's arm onto the other side of the body, like so now. We'll bring the hand, the thenar eminence, onto the lateral epicondyle of the humerus. Take it out of full extension into a bit of flexion and bring them into this position. Now, the problem is that, is that the elbow will cause rotation, medial rotation of the arm as I try and do this. So I have to overcome that, and I'll do that by laterally rotating the arm first. Bring it into that position so it's stable, and I can feel that the elbow is not going to go anywhere except where I'm going to thrust it. I'll have the patient help me again, supinate into my chest the other way, good, and relax, take up the slack, and again, take up the slack, and then we'll simply thrust medially, like so. So we adduct the humerus on the stabilized ulna, in effect abducting the ulna on the humerus, there.
So, to the answers. Dysgeusia, altered sense of taste, is often associated with reduced or absent taste. It is a denervation sensation caused by strokes, VBI, cranial neuropathy, and other things. You've probably experienced it when you had a metallic taste after dental anesthesia. Paraosmia or parosmia is a denervation sensation caused by loss of smell and has a similar cause except for VBI. It includes the smell of seed chippings, feces, vomit, etc. Scotoma is a blind spot in the visual field and may be a floater, retinopathy, or cranial nerve 2 neuropathies or its extensions into the occipital lobe. And dysphonia is an altered voice, usually hoarse and rasping, and may be local, such as laryngitis, or neurological, particularly by the 10th cranial nerve in VBI. And lastly, the calf muscle problem. A is a right DVT with swelling of the calf. There is also some slight discoloration that can just be made out, and in some cases, but not this, there is bruising around the ankle and the foot. You can see the retracted head of the right gastrocnemius in C, which is ruptured. B is due to an L5-S1 disc herniation with right hypertrophy of the soleus. The mechanics behind the hypertrophy is not well understood, but may be due to the muscle's response to the excessive stress being put upon it by weakness of the gastrocnemius. Thank you for watching this webinar. Stay safe, and we'll talk again next week. Bye.